I want to say that a lot of the research and work that I've done here in King County and in Seattle. I went to school here for my master's and my PhD, and ended up with an incredible laboratory and quite a collaborative environment. So I feel very thankful to be speaking here today. So I learned one of the things that I've done a little differently, and I was asked by Nathan Norris to speak about, okay, there's all this research that you guys have done, and we get it, we get the connection. But what can we do about it? Have I got that right? Yep. Not much. No, I'm just kidding. That's the end of my talk. That's not true. We can do a lot. Who was responsible for the Urban Land Institute and the CNU conferences happening at the same time? I think a lot of us. It's quite an amazing thing to see, and actually it helps convey my next point, which is I've worked between academia and practice my whole career. I view them as the two legs I walk on. Create evidence and apply it, but learn from practitioners what needs to be learned. What are the questions? And so that two-way, investigate, apply, learn from application, that is a form of research, and then figure out what to investigate again. And so I think the public and private sectors really, and what I'm going to talk about is, in the end of my talk, the point is thinking horizontally across sectors and also between disciplines. Obviously, we need to figure out institutional mechanism to reward that, and that's what I'm going to get to. But first, I'm going to talk about a little bit, I can't resist, what do we know? So we figured out some time ago that what we build in terms of infrastructure, transportation investments, road and rail, has an effect on what developers and development patterns will be. We try to think so, at least, and when you build transit, you get, at least, should hopefully get, in some places, transit-oriented development, and we study why it happens in some places and not in others. We know that affects behavior, and we measure that. That's a lot of the work that I do, and others, I think, in this room do as well, is did it really work? How do people behave who live in TODs? What about a TOD located this kind of built form in this kind of location with this kind of regional accessibility and travel patterns? So the where and the how go together. That affects health. So in 1990, about 1989 or 90, I was here, and Puget Sound Council of Governments at the time it was called, had a travel survey. Many do, but theirs had a really good sample of active transportation, of walking. I threw that into my models and what research I did when I finished, and I ended up with a paper that people told me when I presented was very ridiculous. Why are you studying walking? No one cares about walking. That is, quote, pedestrian, right? Very stupid thing to say, but it's true. It was very boring. I got warned that your career will be crap. Literally. I was told that by one of the leading people in the field, and I thought, well, you know what? That's a good sign that I should stick with this, because when I got out of bed this morning, the way I got to the train, the way I got around was on my feet, and that's a mode of transportation, and they're idiots to think it doesn't matter. So I published what became one of the first papers on this topic. It was just thinking that it must matter. We need to learn about it. And that affects cost. So what we do a lot now is monetize these relationships. And what we have now, I was just on a tour with the Transit-Oriented Development Council with ULI. We have tools and evidence working here in Seattle and in King County. And if I may just say, Richard Gelb is in the room, who's helped me through a lot of this research. Thank you. And figuring out how do we apply this research and make it practical. And working with people like Richard, I'm taught, make it simple so people can understand what the hell you're talking about. So it can't be too complicated. Let the details be there, but let's just focus on the key points. So we think about it as a metaphor. Built environment, what we build, where we build it, both transportation and land use investments affect human behavior. Not only these travel patterns and physical activity, but social capital, social interaction, mental health. That's a behavior, and we understand these relationships are predictable and systematic. That affects our environment and quality of life. So we try to track performance and how things comply. So now I can't resist. This is the academic version of the research. So I'm just going to show you. I get one slide to be a little wonky, but it's not that complicated. I'll walk you through it, so to speak. So the environment, these are the things that we as planners, architects, engineers, and designers affect. We can work with our clients, government and developers, to decide what transportation infrastructure should be built and where. Land use decisions, walkability, pedestrian environment, design features, seating and lighting and eyes on the street, vegetation, all those things we measured and have linked directly with behavior. physical activity, travel, and other forms of behavior, how well people know their neighbors, based on whether there's seating and good street crossings. All those things matter. We can measure these things, we can put them into software tools, and then we can roll those tools out and predict within neighborhood consultation processes or regional growth and development, which we have. So we have a lot of evidence. And decision makers in neighborhood groups can see, aha, this neighborhood does need to be denser to achieve the goals. If we want to be healthier, if we want to be more active, we're going to have to back into this kind of development pattern that affects and benefits us. That's the evidence part. It doesn't mean the decisions change, but it at least means we have some evidence to show that it matters, and it could actually save a lot of money. So what's interesting to me, though, in the new story here is that, so we understand these things affect our activity patterns and behavior. It affects behavior and also exposure. So we know more compact development creates increased exposure to air pollution. This is a problem, it's a reality. Particulates are more concentrated in places that have increased walkability. So that is a complexity, air pollution, noise, and traffic safety, but these are the biological responses. And I would say the one thing that I'm learning more about is systemic inflammation, our body's reaction to stress, which affects that directly, obviously weight, but actually air pollution affects inflammation that affects diabetes risk. I didn't know diabetes was correlated, not even causally related with air pollution, in addition to cardiovascular. So these are the mechanisms, and we need to understand them. So when we do studies now, we try to get blood work and biomarker data. We work with Kaiser Permanente a lot and others where we sample from their members to have electronic medical record data so we can know before and after the light rail line opens in Portland what the effect was for people who are likely to develop or are at risk of developing diabetes genetically, whether or not the environment caused that to happen. So that's kind of where this data practice is. It's moved from correlation to causation. We drill down into subpopulations. We've had a lot of investigations over the years. So a body of evidence has grown on both the physical and mental impacts. Hypertension, cardiovascular disease, diabetes, and cancer are the main physical ones. Mental health, depression, and dementia may even be more important in terms of the population being impacted so much by it. And then healthcare utilization and cost in the end of the day. So kind of a little bit of a summary. So with increased evidence, scientific evidence, and we've been developing, I'm sure in this room, most of you are very familiar with scenario planning tools. Bringing evidence into the tools that are being used for decision making results in the ability to apply the evidence a little bit more easily, but difficult questions remain. Making the case to decision makers over what form of development to build and where to build it is still always a question, where to invest and so forth, and how to meet the needs of the underserved, more and more understanding the adverse impacts, especially from a health perspective, because it's the underserved, the at-risk populations that are developing diseases, basically lower income, elderly, and other disadvantaged populations. So there are increased opportunities for applying research, but we still don't get to the end game. So what kind of tools exist? We have all kinds of walkability, accessibility indices. We're building a national database. We just happen to be working on this for Robert Wood Johnson Foundation that will roll out soon, which is a surface for the entire United States at the census block group level that has all kinds of measures of built, natural, and social environment, and others are doing great work in this area. County health rankings are helpful and more aggregate. And we know about walk score and bike score, and then health and tools and extensions. There's software tools being built. We're building a couple, one for US EPA called the National Public Health Assessment Model, California Public Health Assessment Model, similar design, basically bringing health into scenario planning so that decision makers look at the cardiovascular, diabetes, and other risks from their long-range transportation plans, which rolled out can extend to being huge amounts of money saved. So there's a lot of investigation and benefits. Visualization is a really important tool, as we know. I think that's what we try to do with our clients in planning and architecture and design, is to help them understand and visualize the real implications or what a place would feel like and look. I know many of you work on that. Actually, one thing to mention is the cost benefit is measuring expenditures and benefits is new. That's only in the last 2 years have we really been able to monetize, and I hope to get to that end of my talk a little bit, is we now have not only healthcare utilization and cost reductions from increased walkability, we also know that workforce productivity is significant, even more so significant than that in terms of dollars. So we try to monetize these outputs and the health models and through input-output modeling. We're taking the tools that transportation agencies, super agencies are using to say, should we build a rail line or widen the road? And actually saying that same tool that was argued for all these years, that congestion and delay, actually cost us so much money that we couldn't afford to not to widen the road. That same loss of productivity from sitting in a car is now being turned in our models into an incredible savings from a healthier workforce who are more productive and go to work and don't miss days because they're sick. The dollars are huge. In fact, bigger than the infrastructure themselves in many cases. So visualizing conditions, percentage of population, mapping, we're all very familiar with these tools, very powerful. In fact, decision makers will often gravitate to some of the simplest things we can do, just describing things and where the problems occur and layering different types of information, demographic and physical and others on top of each other. Another example, this is in San Diego, predicted moderate and vigorous physical activity. So we can take our tools and extrapolate across landscapes and show where people actually walk more and where they're healthier. Of course, La Jolla has a lot more walking and wealthier areas, but also downtown San Diego near Balboa Park and places that are truly more walkable. Lots of debates are happening, though. When I presented this map, and some of the data we did in San Diego, the planning directors were in the room at SANDAG, Association of Governments. The planning director from Coronado Island came up to me, and she said, we're more walkable than downtown. I don't believe your map. And I said, well, it's just based on real information. It's how much people are actually walking, and we didn't make it up. She's like, well, it's wrong, because we have people, they come home from work, they walk around at dinner, they walk, and then another guy came up from North County on the ocean, very wealthy areas. They see a lot of people out walking at certain times of day, but how do they get to work? Well, there's not many jobs in Coronado. It's a recreational, very wealthy, more residential and high-end community. So now that walkability is a trademark for value, you're getting a very political, heated debate on it, and it's quite different. And in fact, the other piece and the other end of it is we cannot do studies showing that about walkability's benefits anymore without addressing housing affordability, because we've sold the idea, many in this room. We won. It costs too much now. So we have undersupply. So that's how in Vancouver, where I live, here in Seattle, it's all about how you're going to deal with housing plus transportation costs and integrate it. Because we're going to just show one more time the benefits of walkability, and it's even becoming politically more difficult. So they get the argument. The question is, what can we do about the supply? This is in Los Angeles, just showing, I thought I'd provide an example. This was an aggressive scenario for their long-range plan. We've worked a lot with Southern California Association of Governments and a very progressive in Los Angeles group, and we saw that they're looking at a reduction, of population, poor population health reduction by 13%, obesity down 3%, high blood pressure 1%, and type 2 diabetes 11% from their plan. That would be incredible. That's like 20 million people, a 10% reduction, 2 million people fewer that had type 2 diabetes. That alone, that was not the plan they implemented. It was a very aggressive one, but we're seeing a 1% reduction yields something around $50 billion in savings over the life of the plan. The numbers are astronomical because health is, healthcare is expensive. So I just run through one scenario, and then I'm going to talk a little bit about what I think we can do with all this information that has been accumulating. So this is an example of a case study that we did in San Diego where we developed all our research and then we applied it to a software tool called Envision. This wasn't Envision, this was CommunityViz. How many are familiar with CommunityViz? Envision, Urban Footprint, These are the three we work with. So we've developed an API, a plugin. So the research we do that links all these design elements that you work with health outcomes is now wired into the software platform, so you can do what-ifs with your clients and community groups and actually roll it out directly. And that's something we can talk more about if you're interested. So basically, this is a small area, Palomar Gateway, down near the Mexican border, a San Diego trolley line. The city of Palomar had an aspiration to add 3,000 people and make this place much more walkable. That's their plan. We just compared it to current condition. And here's what we got in terms of results, and I'm just going to jump ahead. Well, this was actually, I guess I put in their program was they're adding 3,000 people, and they're going to go from single to multifamily, and then if you look down the list, you'd see a bunch of other amenities being added and uses, making it more mixed use and more walkable. And the outcomes were a 68% increase in minutes of daily transportation, 15% reduction in high blood pressure, about a 9.6% reduction in type 2 diabetes in adults. Youth are a little different. Air pollution exposure goes up and risk and injury go up too. So some of the results on youth are a little bit more perplexing. Physical activity increased, but obesity and prevalence for teens was also predicted to increase, as was asthma, which we do understand because we measured distance to busy streets and captured the effect of air pollution exposure. And then collision risk also increased. So there's things that we need to do while we make our places more walkable to mitigate adverse impacts. Let's see if I can get this to work. So this is the monetization story. In Los Angeles, their long-range plan, they are going to spend around $13 billion in active transportation infrastructure over the life of their plan. That currently would yield about a $4.5 billion payoff just in terms of healthcare savings from, as you can see here, from diabetes, heart disease, and hypertension. So these are the millions per year. That's just annual savings, and then it racks up over the life of the plan. So it's kind of interesting because that alone is a big number, but the savings don't pay for it on its own. It's about a third, and that does not include seniors. When we loaded seniors into the model, it actually was paying for itself nearly, because most of our healthcare costs are in the latter part of life, and we have an aging population as well. So when you roll that forward, it becomes bigger. But here's kind of the big upshot of all the research that we've done recently on this is we found about an $8 payoff for every dollar spent for investing in active transportation. That's an enormous number. It scared us. We hired AECOM, who's a very reputable engineering firm, to run these numbers. So if you have any questions about the number, you should talk to them. But no, it's pretty exciting, and when you break it apart, it makes sense. Part of it is, as I mentioned, it's workforce productivity. Part of it is the dollars stay in the economy. When we build active transportation infrastructure and transit, that's more labor intensive than material intensive like roads are. So that means that the money stays in the economy, gets spent by the people that are doing the work, and you get this huge multiplier effect. That's how it was explained to me, and I think it's pretty interesting. We have a three-pronged argument for why this makes economic sense. Now, we all know that one of the biggest arguments, without all the benefits of these investments, we have an unmet demand. It's probably enough to argue, or should be, that maybe we should build this because, in fact, there's an enormous demand for it. And a lot of the work that Todd Zimmerman's done and others show this unmet demand. This is just one example. You probably could think of dozens of studies showing the same thing. I think we're all pretty familiar. It's evident because the market is there. The dollars per square foot are enormous. I heard a number today. The dollars per square foot for the Hudson Yards in New York is, on the condos, is $3,000 a square foot those condos are selling for. It's $2 million to get in. You know, so people are really willing to pay to be in the most walkable areas of our cities. Vancouver is off the charts. Seattle's having the same problem. So I think we get this point. So translating evidence into action. Well, years ago, I was in Atlanta, a professor at Georgia Tech, and I met my sponsor here today, Laura Heery and Ellen Dunham-Jones at Georgia Tech. And Laura, thank you for making my ability to be here. She sponsored my membership here today. I learned a lot from Atlanta, and I continue to. And we were asked as part of this project we had called Smart Track. It's the study where we showed driving makes you fat. I don't know if you've ever heard about that, but we did that. It's been repeated around the world, and it's so obvious that I get teased for having done something so basic and so simple, but it made sense. Government, lenders, and developers, 3 groups. If you ask a developer, at least back then, why couldn't you, what are the barriers? Why can't we get this to happen? They would say, well, I either can't get the money, but if I could get the money, I would have a hard time getting the development regulations to work. In the progressive parts of the United States, that's not as much a barrier anymore, but it's still happening. It's still a barrier, so we don't hear where are the lenders, the bankers and the financiers on this now? Is there still increased risk perceived from building non-traditional or non-conventional suburban development? So, uh-oh, I just lost 5 minutes. He told me I had 10 and it went down to 5. If you do that again, I'll need to leave, huh? Right, okay, right away. So if you ask lenders, well, the lenders have their arguments. So we can talk to each of the sectors of the economy. Our clients are mostly, I would think, government and developers in this room who we work for, different layers of government. So what it made me think about was, it depends on who you're talking to, what you might say. Evidence is one thing, but evidence alone won't make action. But I think the lack of evidence can make action pretty difficult to argue for. You have no basis to argue that well, tell me, prove it. Especially if you're going to rezone something and take something away from someone in a place. A transfer of development rights, for example. That you better have good evidence because it could end up in court. And I'm going to actually get to the legal system at the very end because I think our biggest opportunity is that. So I think we need to learn the messages that we give based on the audiences that we're providing and what kind of evidence to package. So intergovernmental and intersectoral partnerships, dollars spent on transit and active transportation are now a form of preventive medicine. We need to think of it that way. If we want to use the health argument, we're talking preventive medicine, but there's a problem. If that's true, then the dollars saved from healthcare cost reduction and improved workforce productivity accrue to the healthcare providers and sector and government entities that are involved in that part of work. It's a different pocket. So we have what's known as the wrong pocket syndrome. So I give you an example. You would think it's simpler in Canada. So I live in both and work in both countries where public healthcare system, where we have local governments get that it's preventive medicine. They should be building all this good stuff to make people healthier, but it's the province that provides health care. The province saves the money, but it's expected to come from municipalities. So why doesn't the province and why doesn't the health authority pay for all this transit and active transportation infrastructure? Our medical health officer, chief medical health officer, Patty Daly, we had a referendum in Vancouver that you may know of that went down. Patty Daly, our medical health officer chief, she was the biggest advocate we had. She said in front of everybody, the best single thing we could do for healthcare is build this transit line. We still didn't get it built. It still went down. People are still stuck in the kind of whose pocket, who's saving the money, and so forth. So we need senior government, higher levels of government to make it institutionally rational for these sectors to work together, and I think that could be done. Funding from health sector is not available as well for prevention. Budgets consumed in reacting and just treating all this chronic disease that we already have from our obesogenic environments. So the most expenses occur during the last few months of life as well. That's a separate problem that we could try to address, obviously very difficult in many ways. So engaging other actors, professional organizations, well obviously CNU. Recreational public sector and recreational private sector, so forth, is our clear hits on that. NGOs, America Walks has got a consortium now. I work with America Walks very closely. I'm on the board now, and I think it's a wonderful organization that has a lot of opportunity because they have, in addition to quite a long history in this area, have formed a network of NGOs that you can reach throughout the country, and that's really exciting. In smart growth, we know so many other organizations, but as individuals and professionals, we are professionals as a distributor of evidence, tool users, and facilitators for professional organizations, setting practice standards. Should all comprehensive plans perhaps, should we argue, have a health element, and continuing educational opportunities and training on evidence and tools, and supporting legal and regulatory strategies. And I think my last point is, I started my career in this health stuff on this question thinking this is really interesting. We know that zoning, our key tool, is predicated legally on what? 1926, health, safety, and welfare. We have enough evidence to prove that exclusionary single-use zoning and many other attributes of zoning are measurably unhealthy. We know that. So, we know this is where it's going to need to go, is we need to, places that reduce ability to walk and require sedentary vehicle travel, adversely impact disadvantaged populations, and so forth, are bad for our health, so maybe we can do something about that. Thank you.